The next speaker is the Ruth Origin, the chair of the medicine, and Charles A. Doyle, professor at the University of Rochester. Should stand on the side, please.
Okay, well, thank you very much. So I'm going to tell you that, of course, all CDK inhibitors are not the same. It seems to be. Okay. So in full disclosure, I'm an advisor for all three companies, so that can't be held against me. Just a little bit. But. Okay, so first of all, looking at their structures shown here. So they are similar, but you can see there's also some differences. And what we're looking at here is the IC50, and I want you to look specifically at the IC50s for CDK4 and CD46. So if you look here, what you find is that abemaciclib has very low IC50s for both CDK4 and CDK6, and the IC50s for ribociclib are higher, and also palbociclib is kind of in the middle. And that may make some difference in terms of some of the things that we see, or the differences that we see between the drugs. So Dr. Pat went over this, but I think this clearly illustrates they're not all the same. So first of all, we have the issue of neutropenia being more common with palbociclib and ribociclib, which means, and that's the reason that we give them 3 weeks on and 1 week off, versus abemaciclib, because it causes less neutropenia, can be given continuously. Deb talked about the diarrhea associated with abemaciclib compared to the other two agents. Abemaciclib also has been shown to increase creatinine levels. She talked about the QT prolongation with ribociclib, and then I think we're learning that all three of them cause pneumonitis. But I think looking at the toxicity profile, I don't really need to go any further. They're clearly different. Getting on to the first-line trials that Deb talked about, I think I will admit that the hazard ratios when you look at progression-free survival across the trials are remarkably similar. However, I think, as she pointed out, there are differences in survival. So, if you look here, all of the Mona Lisa studies that had first-line patients do show a significant overall survival benefit. And Monarch 3, even though it's not statistically significant by the trial criteria, it is a 12-month difference compared to 3 months with Paloma 2, as you can see. Now, Dr. Pat did stress that there were limitations in Paloma 2, and I'll certainly give her that, but I think that I always look at the control arm on these studies, and I think if you look here at the endocrine therapy alone arm, they're remarkably similar. They all are 51 to 54 months. There's not really any difference. The difference really is in the CDK inhibitor arm shown here. So you can see there's no question that the data with palbociclib is not as impressive in terms of overall survival compared to the other two trials, and you can see the curves shown down the bottom. So again, I think that's kind of where I'll rest my case. No. But now I just wanted to talk about just some areas where there is higher level data for one of the drugs versus the other. And I'm going to say from the get-go, in some cases we just don't have data for some of the other drugs. So I don't know we can say that they're necessarily better, but that's where we have the data. So Deb mentioned Mona Lisa 7, which I think was an important trial because this is only the second randomized trial that's been done in pre- and perimenopausal women with ER-positive metastatic breast cancer. And as you recall, patients received endocrine therapy with either a non-steroidal aromatase inhibitor and tamoxifen with crisarilin, and then were randomized to ribociclib or not. And the progression-free survival shown here, you can see clearly is in favor of ribociclib. And the overall survival shown here, you can see the curves also separate in favor of ribociclib. I will say that there's been retrospective analysis done from all of the frontline trials, and they all show similar efficacy in pre- and postmenopausal patients. But if you want high-level randomized data, this certainly would favor ribociclib in this setting. Now, Deb also mentioned the Right Choice trial, which I think was a really interesting trial that was presented at this meeting. So this was patients who were pre- or perimenopausal, hormone receptor positive, but had what they described as aggressive disease, which could be symptomatic visceral metastasis, rapid disease progression, or impending visceral compromised, and markedly symptomatic non-visceral disease. And you can see the total bilirubin had to be less than 1.5. And they got randomized to doublet chemotherapy, so you can see the different regimens shown here, or ribociclib with a non-steroidal aromatase inhibitor and gazarilin. Patients were imaged more often than usual, every 6 weeks, because of this aggressive disease that they had. And it is a randomized phase 2 study, so not a huge number, not the number of patients that we typically see in a phase 3 study. But here's the results, and this is really, I think, such important data, because what you're seeing here is that the patients who got the CDK inhibitor plus endocrine therapy actually did better for progression-free survival compared to the patients in the chemotherapy arm. And actually, the PFS in this study, 24 months, is very similar to what we saw across all the first-line trials. So even though these were patients that really had, very concerning disease, they actually are doing very well with the CDK inhibitor. And I think, although this is a phase 2 study, I do think this is kind of practice changing. Other things about this trial, I think this is a group of patients where we want to see a response rate. And you can see here the response rate was higher in the CDK, the ribociclib endocrine therapy arm, and clinical benefit rate of 80%, which really is very high, as you can see. And then I think the big question is, the reason we use chemotherapy is because we think it tends to work more quickly than endocrine therapy. And they looked at that here, and you can see the time to onset of response was similar for ribociclib and endocrine therapy compared to the combination chemotherapy. So I think a lot of us were doing this, but I think this really moves us away from using combination chemotherapy in the first-line setting. What about single agent? Obviously, this is an old study, the first study that came out with abemaciclib, Monarch 1. And if you recall, these were patients that had very heavily pretreated hormone receptor positive metastatic breast cancer. They had not received a CDK inhibitor, obviously, because they weren't approved at the time. And you can see the waterfall plot here showing that this single agent abemaciclib was really pretty effective with the 20% overall response rate and a clinical benefit rate of 42%. If you remember, both ribociclib and palbociclib were looked at as single agents, when they were doing phase 1 evaluations. So, but again, this is the one phase 2 study with a single agent CDK inhibitor. Deb also alluded to this. So this was a phase 2 study that looked at abemaciclib in patients with hormone receptor positive brain metastasis. And you can see here, with this waterfall plot, there were patients who had partial responses, stable disease, and overall the intracranial response rate was 5%, and the intracranial clinical benefit rate was 24%, as you can see shown here. So again, this is not to say that the other two CDK inhibitors would not be effective in patients with brain metastasis, but this is it's with abemaciclib where we have this phase 2 data shown here. What about continuing CDK46 inhibition through progression? Well, this is the MAINTAIN trial that was presented at ASCO this year rather. And what they did here was they took patients who'd had CDK inhibitors and endocrine therapy in the first-line setting, and they randomized and received endocrine therapy with either fulvestrant or exemestane, or to ribociclib with fulvestrant or exemestane. And you can see here that the patients who got the ribociclib had just over a 5-month progression-free survival compared to 3 months in the control arm. It's important to recognize here that most of the patients on this study had received prior palbociclib, so they switched both endocrine therapy and their CDK inhibitor. And then this morning we had a great presentation from Dr. Meyer on the results of the PACE study. I just pulled out the endocrine therapy and CDK inhibitor arm of this. So this was patients, again, who'd received first-line CDK inhibitors with endocrine therapy, an aromatase inhibitor, and they were randomized to fulvestrant alone, fulvestrant plus palbociclib, or the third arm that included the checkpoint inhibitor, which I didn't include here. And you can see, in contrast to MAINTAIN, there wasn't any difference here. The progression-free survival was about 4.5 months on both of the arms, as you can see shown here. However, I will say, in fairness to Deb, if she says this, but I think this is apples and oranges, because the majority of patients that entered this study were on palbociclib, so you weren't switching the CDK inhibitor, so it's not the same as the MAINTAIN study. So I'm going to put that caveat in right away. Just talking a little bit about the adjuvant setting, and we saw Dr. Johnston updated Monarch E earlier a few days ago, and as you recall, this is patients with high-risk ER-positive early-stage breast cancer, randomized to endocrine therapy alone or endocrine therapy with abemaciclib, and we saw a separation of the curves very early on. And what's so nice to see at this meeting is that the curves actually, if anything, have continued to separate. And right now, 99% of these patients are off treatment, so there appears to be a carryover effect of abemaciclib in this patient population. So obviously, this is very encouraging data. In contrast, again, Jeb mentioned this PALIS, lower risk group of patients to the Monarch-E study. They were randomized to endocrine therapy with or without palbociclib, and no difference in the endpoints. You can see the curves are totally superimposable, and no split of the curves at any point. This was with a follow-up of 2 years. And then the other adjuvant trial was Penelope-B, which took patients who were very high risk. They had residual disease following preoperative chemotherapy and also had to have a CPSCG score of greater than 3 or greater than 2 with no positive disease. And as you remember from this study, the curves initially separated. They were randomized to receive endocrine therapy with or without palbociclib, but only for a year. And you can see the curves did separate at 2 years and even at 3 years, but then came together at 4 years. So overall, this was a negative trial. Just to point out here, the median follow-up of Penelope-B is now the same as the median follow-up on the Monarch-E study. So I think that's why the data from the Monarch-E study is I think, very encouraging. So I just added a few extra lines onto the chart that Deb had, but just looking at them, comparing them indirectly shown here, she's gone through a lot of this already. Just to point out, the reason I think they're different is because of toxicity, the schedule that they're given in, the data in the first-line setting shown overall survival advantage with some CDK inhibitors and not others. The data in the premenopausal setting, but I do think that they all have data in that setting. It's just the randomized data with ribociclib. Impending visceral crisis, we saw the right choice trial showing that patients did very well with ribociclib and endocrine therapy. But again, I'm not saying that this would not be the same with palbociclib and abemaciclib. We just don't have the data. Single agent activity, I put question marks here, but I think they probably have some single agent activity. But again, the phase 2 data is with abemaciclib. Brain mets, again, they may all get into the CNS, but the phase 2 data is with abemaciclib. And then efficacy through progression, I put yes for ribociclib. We don't know about abemaciclib. I put no for palbociclib, but I do think that's a little unfair because the trials are so different, and they really stayed on palbociclib on the PACE trial, whereas they switched on the MAINTAIN study. So overall, hopefully, I've shown you that the evidence is completely irrefutable that CDK inhibitors are not all the same. So thank you for your attention.
Yes, thank you for a wonderful talk.
Great job,